Dr. A.K. Das, Dr. Alok Kanongo, Dr. Jayant Panda, and the team of NUCD for this honor. Without wasting much of the time, let me have very little introduction of maybe 1 or 2 minutes. That's 1970, the global obesity prevalence has nearly tripled in adult since last almost 4 to 5 decades. And it has become an epidemic now. It contributes to reduced life expectancy of around 20 years. And obesity pandemic may create an multiple health burden for the society, which Dr. A.K. Das has just alluded to. As far as India is concerned, we have a few of the areas where we have very high prevalence of obesity, almost more than 50%, which includes some part of the Andhra Pradesh, Tamil Nadu, and some north and northeast region. Maybe not northeast, but Orissa, Maharashtra, Telangana, Karnataka, maybe in the second space. I don't want to go into detail of causes of consequences, but certainly it is the sedentary lifestyle, environmental factor, genetic predisposition, and lifestyle disease, like life reasons, like might be calorie intake or maybe high calorie, high fat diet, which all leads to insulin resistant dyslipidemia, hypertension, diabetes, NAFLD, sleep apnea, cardiovascular disease, cancers, osteoarthritis. I feel the list is still incomplete. Almost each and every organ of the body can be affected through obesity. We also are aware about the thin fat Indian concept that we look thin, but we have visceral obesity, and despite having a low BMI, we are having a good amount of central obesity, and this becomes a atherogenic risk factor for the population. And this category also comes in sometimes into as a different category of obesity. So Asian Indians are phenotypically thin fat, and they have thin fat obesity. They have central obesity with high waist hip ratio. They have small body size, yet high fat body percentage. Central obesity, greater body fat for any given BMI versus Caucasians. They are more prone to have high triglycerides, hyperinsulinemia, and greater insulin resistance. And there are multiple publications on these lines. Now, when we talk about this particular category, we have thin from outside and fat on inside. That is what is two the important category we have. We have on extreme right is normal lean patients. You have normal weight central obesity, and you have metabolically obese but normal weight. And on the second in the category is metabolically obese people. So they are obese, but they are metabolically healthy. And this is what is my talk to cover. How does the metabolically healthy people, are they better? Are they don't have any risk, or are they have equal risk but a slow progression? And what is the reason behind it? So how do we define metabolically healthy obesity? Is a concept derived from the clinical observation that there is a subgroup of patients where obesity do not exhibit the cardiometabolic abnormality. So we do see people who are obese. We have high BMI, maybe more than sometimes 30. We don't have a cutoff for Asians for metabolic healthy people at this moment of time, and there is lack of consensus across. So still we take 30, but we can certainly go for 27 as we have a cutoff of our own population from 23 to 25 and 25 to 27. For metabolically healthy people, the prevalence is around 10 to 30%, and it varies from different population. And it is also being quoted to be a transient phenotype rather than a permanent phenotype like others. So obesity, it is being defined as a BMI more than 30 plus some of the following cardiometabolic risk factors, which could be fasting triglyceride, which is less than 150, HDL cholesterol in men more than 40, women more than 50, blood pressure is normal, systolic less than 130, diastolic less than 85, and fasting blood glucose less than 100, and the person is not on any of the treatment of dyslipidemia, diabetes, hypertension, and have no cardiovascular disease manifestation. So if some particular obese person with a high BMI of more than 30 have these characteristics, and then they can be called as a metabolically healthy individual or obese people. There are also different food of thought, and the recommendation that some of the studies have covered less than 2, because in metabolic syndrome, you keep more than 3 risk factors of central obesity, hypertension, low HDL, high triglyceride, and glucose intolerance. Out of these, if you have less than two or less than 2 risk factor, they are also being defined as metabolically healthy individuals. There are some so this is the basic criteria which I told you, but there are some advanced criteria. Now they even try to consider the lipid content in the liver, so intrahepatic lipid content and non-alcoholic fatty liver disease, some of the parameters of insulin sensitivity. So this again has been considered. Now these individuals have less ectopic fat storage. They have high leg. I'll just use the laser pointer. Yeah, high leg fat deposition. They have preserved beta cell function and have better cardiovascular risk, fitness. So they are being called as metabolically healthy. So there's another kind of proposition that a protective characteristic of people with metabolically unhealthy versus those who are healthy. And if you see less than 2 metabolic syndrome component, they could be called with low HOMA-IR, so low insulin resistance, no metabolic syndrome component. If you have low metabolic syndrome component and low HOMA-IR, so lower is the risk factors, more you are towards normal obese people. There are various mechanisms which could be responsible for this kind of healthy obese people, they have it's a type 2 diabetes, non-alcoholic fatty liver disease, and hypertension, dyslipidemia at a background, which could be responsible for cardiometabolic risk factors in those who are unhealthy people, and they have chronic energy imbalance, genetic risk factors, increased size of the adipocytes. They have more of ectopic fat in the liver, less fat at the leg, and adipose tissue inflammation. They have adverse signals from the adipokines, metabolites, and immune cells. There could be subclinical inflammation, which again promotes how do we explain metabolically healthy individuals. So the inflammation might be less, which seems to be more in the unhealthy individuals. So MHO individuals exhibit low level of inflammatory markers, which includes CRP, TNF alpha, IL-6, and the white blood cells. Lean individuals have abundant, sometimes anti-inflammatory adipokines and adiponectin, which again could be, while the obese individual have more pro-inflammatory adipokines. Obese people with type 2 diabetes have elevated inflammatory markers. We know adipose tissue inflammatory markers such as TNF alpha and IL-6 are elevated in morbidly obese patients. So if you have less inflammatory markers, and that has been observed in patients who have metabolically healthy obesity versus the unhealthy obesity. And then the second concept is adipose tissue expandability hypothesis. And this is a new hypothesis which every one of us should know. Each individual possesses an intrinsic limit on their capacity to store lipid in the adipose tissue. Once this limit is reached, adipose tissue can no longer effectively store lipid, and this is being directed to other organs, more commonly to liver. So adipose tissue mass increases dramatically with obesity on a cellular level. It leads to both adipocyte hyperplasia and hypertrophy. If not properly supported through the appropriate extracellular matrix remodeling and neovascularization, adipocyte hypertrophy can result in adipocyte stress and the cell death. And this is what is the role of adipose tissue in metabolically healthy obese versus the unhealthy obese. The white adipose tissue is the primary lipid storage organ. It regulates the systemic energy homeostasis by controlling metabolic flexibility and lipid fluxes in the other organs. This white adipose tissue secrete adipokines and regulate energy balance and systemic glucose lipid metabolism within distant target tissues such as liver and muscle. And the prolonged nutrient overload can cause metabolic state, and a state of adipose failure and dysfunction ensures, resulting into into the loss of metabolic flexibility. And what this metabolic flexibility is, there's the ability of the body fat to efficiently switch between the different energy sources and adapt to change in nutrient availability and the energy demand. It refers to the body's capacity to shift between the use of glucose and fat as a fuel, depending on the availability of these nutrients. In a metabolically flexible individual, body can effectively switch between the carbohydrate and the fat metabolism, and individuals who lack the metabolic flexibility may have difficulty using the fat as an energy source, leading to reduced endurance, increased fatigue, and increased risk of metabolic diseases like diabetes, obesity, and insulin resistance. Now, what is the natural course of this metabolically healthy obese people? Around 50% of the healthy obese at the baseline were unhealthy obese after 20 years. So in progression, if you see, maybe the progression from the normalcy to obese and unhealthy obesity could be a little slow in these individuals because of the decreased inflammation, because of increased flexibility in the adipose tissue. The risk of type 2 diabetes in these individuals is more, and that has been type 2 diabetes and other metabolic risk factors is more in these individuals if you have unhealthy obesity. But if you have healthy obesity, it is associated with substantially lower risk to compared to the unhealthy obese. So if you are unhealthy obese, you are more likely to have metabolic syndrome and diabetes and the cardiovascular risk versus the healthy obese people. But still, it does not mean you are as that of normal. If you go through this graph, metabolically healthy lean subjects versus metabolic healthy obese and unhealthy obese, the risk of cardiovascular disease is little high, risk of heart failure is little high, cardiovascular event is little high, and all-cause mortality also seem to be high, and diabetes seems to be again high versus these who are metabolically healthy lean subjects. So risk of cardiovascular disease, events, and type 2 diabetes all-cause mortality seems to be high in these individuals versus the lean, healthy metabolic individuals. Now, how do you apply this to this concept of metabolically healthy obesity in the clinical practice? There's an increased risk of individual with metabolically healthy in obese people for type 2 diabetes, cardiovascular disease, and heart failure as shown you. There's a data about the controversy on the metabolically healthy individuals and the cardiometabolic risk and all-cause mortality. So they have a pooled analysis for 18 studies, 10 years follow-up, 42% greater risk of cardiovascular events. There is no increased risk of mortality. There's a prospective cohort study, 10 years follow-up, no increased risk of cardiovascular disease in elderly population if they are metabolically healthy. Meta-analysis of prospective study of 20 years follow-up, 4 times greater risk of developing type 2 diabetes. So still we have lack in the consistency of various results. And this is again the same data around 5 lakhs people. And ultimately, after further analysis and exclusion criteria, around 8,500 were observed for their metabolic status and the inflammatory markers. This is the basics of various metabolically healthy individual, healthy obese, this non-obese, unhealthy non-obese, and unhealthy obese people. And I'll just directly go to the results part. So association between diabetes seems to be higher in even unhealthy obese and even in healthy obese versus the normal normal weight or non-obese individuals. Association between the cardiovascular disease again seems to be when you compare it with unhealthy, seems to be almost similar here, as well as in the little even higher here in the cardiovascular disease respiratory outcome. When it comes to cardiovascular respiratory outcome further, in these individuals, it seems to be almost similar if you see the metabolically healthy obese versus unhealthy obese. For other health outcome, again, the healthy versus unhealthy seems to be more towards the increased risk. Now, cardiovascular metabolic risk. This is again a data from Go on Gave 2016, around 14,800 patients, and they have classically shown the 3 groups: healthy, suboptimal, and unhealthy. Suboptimal are those who are obese without metabolic risk factors. They are almost on the same line, but much higher than the healthier when it comes to coronary artery disease, stroke, and cardiovascular mortality rate. Even about diabetes, if you compare healthy versus suboptimal healthy versus unhealthy, the suboptimal healthy is nothing but those who are obese or overweight people who does not have any metabolic risk factor also seem to be at a higher risk versus the healthy individuals. And this is again almost on the same line. So do we need to move beyond BMI and should we think further? So we have a proposed clinical staging system of obesity now, and there's a paper which again now come out with considering other factors, not just apart from the obesity and BMI. So if you have a stage 0 obesity, if you don't have any of the medical, mental, and functional abnormality, which goes from stage 1, stage 2, stage 3, and stage 4 with associated comorbidities. So now we have considered it's not only the BMI, but also the functional, mental, and the medical associated comorbidities in these individuals. And this is called as Edmonton Obesity Staging System, EOSS, where different parameters have been considered, and accordingly, the obesity should be classified and treated for. And these are with different staging with no risk, and the level of prevention could be from the primordial lifestyle modification, stage 1 behavioral changes, and stage 2 you can go for secondary prevention. Stage 3 is complication, which is significant tertiary prevention, and maybe medical and surgical treatment has been offered. And stage 4, of course, the tertiary prevention. So you have staging. To conclude this my session, the takeaway is many prospective meta-analysis have indicated that people with metabolically healthy obesity are at increased risk of type 2 diabetes as well as cardiovascular disease, heart failure, and some have shown the increased risk of mortality. The recent data indicate that they have higher risk of all-cause mortality, ASCVD risk, heart failure, and respiratory disease. They represent transient phenotype leading to increased risk of ASCVD and all-cause mortality, and usually progress to a metabolic deterioration in years to come. Maybe the progression is little more slower versus the unhealthy obese people. Hence, using MHO is a misleading and should not be used, in my opinion. With this, I stop here. So every person with so-called metabolically healthy obese need to be focused for prevention from the right away from the day of diagnosis, and given the advantage of all anti-obesity measures versus that of the lean, healthy individuals, and as well as versus the unhealthy obese people. And this particular slide.
Thank you very much for this great lecture. We'll come back to the questions